how do we get out of this guy? Hi, how are you, Scott and White? Yeah.
How are you?
I am well, but I don't know how to get out of this guy here. That's the way to do it.
So how do you
What we're
get
gonna
there?
do, we should be set. What we're gonna do is you're gonna go first, and then we'll just go in order. So you'll be first.
Caleb.
You'll be second. Oh, you're from Scott and White too?
Yeah.
All right. Did I meet you guys before?
I don't think so.
'Cause
But I know your name.
well, back a long time ago, I interviewed at Scott and White.
Did you? How many years ago?
That was a long time ago.
No, I moved there. I was at the Cleveland Clinic. I moved there 12 years ago. And this guy is younger than me.
It was probably 94.
No, I was in Cleveland at that time.
Hello.
So, do you have kids?
I think we're good. It looks, I hope they're all there properly.
Yeah, I know. But the only thing is your talk is what?
Okay, well, we'll see. And so that's off at the moment, and then if we need it, we'll turn it on. And we still have 15 minutes,
Yeah,
right?
it should be
We have 11 o'clock.
5 minutes for the case part.
Okay.
After that,
And so we each have about 10 minutes? But your case is not long.
yeah, it won't take very long. It just depends on how long it takes the answering question part.
So we should have about 45 minutes, so maybe what we'll do is we'll entertain questions at the end.
At the end. Yeah. Otherwise, we'll
Okay.
Okay. Are you guys together? No. He's back.
Yeah. No.
So let me tell you what a guy told me first time in 93, like you said, like 92. When you're and I tell you, this would be no, except that one hand, where you know more than everybody. Just show and just look at me. They will.
Yeah, so it should be fine.
There's water here.
We may need a fifth chair. That's okay, we can do that too.
Just download files and
Okay, so yeah, so if you haven't done this, all you have to do is click on here and it should come right up. Now, one of the things that this did, so you want to leave that on, and what you can do, in fact, if you just leave that there, I'll give people some prompters about this. The thing that's disconcerting, good but disconcerting, is when your slide comes up, you're going to get a preview of the next slide.
yeah.
And when I first did this yesterday, I thought I wasn't on a full screen app, but you are for the current slide. So you're going to see this template all the way through. And even though your slide on here will look like this, it'll look full slide scale. Okay? You're a fellow?
Yes.
Third year fellow. You can sit down. We've got a few minutes, right? Where's my timer? I'll show you when he finishes. What happens is you get a command.
Is that seat available?
All of our talks.
Tim?
And then you just
Actually-
your talk. What I was telling him, what I found a little bit disconcerting is usually the speaker's computer
Thank you, Doctor.
replicates what's up there, and this does not. What you have is you have a split screen,
Tim?
and you have your current slide and your next slide. And your current slide is actually full screen up there. So just so you guys know that, because I was messing around with it trying to make it go full screen yesterday, and I looked over and I realized I already was. So, sorry, what year are you fellow?
Third year. I signed with the hospital last September.
Okay, so you're staying in
Yeah.
Kentucky?
Yeah. Eastern Kentucky. So
That guy.
actually worked for him. He was throughout my residency. He was there. I went to California. Came back for the VA, so I've actually been back there too. He runs all the line too, so that's the he's pretty good.
He was one of our fellows, one of my fellows. In fact, when he was a
Is
resident,
that seat available? Thank you.
I think I did. That's what I.
There's a couple seats here. One more.
But do something else.
Yeah, he told me that education fellowship I had somehow messed up. I had to put my board scores on. So I had no idea because the interviews were coming in, but he didn't tell me. And then which would have been horrible had I not done it. He came and found me, told me I needed to make sure I had my board. Because he used to also be on fellowship program as well.
Glad you're here. You guys stand all the time.
Chair over here. It was standing in this corner.
How do you know?
I'm doing great. Hey, hey, Bob. Yeah, good.
I'm gonna grab a chair. Come on up.
This side? All right, excellent. It's gonna be a world tour in 1 hour, right? You think I speak fast?
We've got minimal time. How about if I get started, if we're a couple minutes early starting, that's good because we all have such limited time. Good morning. We've got a full room today. I'm glad to see you all here for an exciting series of talks. We're going to talk about the management of severe hypoxemia in our patients with ARDS. My name is Dr. Dan Ouellette. I'm at Henry Ford Hospital in Detroit, and I'm honored to be the chair of this group. We've decided to come all up here to the front. We're having, because you guys have taken all the chairs, but we have a different kind of a session today than most of us are used to. Today's session, we're going to start with a case, and then each of us has about 10 or 12 minutes to talk to you about one element of management that we think is important. And I hope that afterwards we'll save some time so that we can all talk about things and talk about how we take care of these very sick patients. So welcome. Our first speaker is going to be Dr. Mienick, who is at University of Kentucky, and he's going to present a case to us. Dr. Mienick?
So, refractory hypoxemia and ARDS. Say I'm Caleb Mienick. So, I present a 19-year-old female presented to the ER with intractable vomiting. About 30 minutes after arrival, she aspirated a large amount of gastric contents, had a PEA arrest. ACLS was performed for about 20 minutes. She had severe refractory hypotension and shock, requiring multiple vasopressors at that point in time. Only history of asthma initially, and no alcohol or drug abuse in the case. Labs were significant for a white count of 15.4. Her gas is shown a pH of 6.7, PCO2 of 54, and a PO2 of 66, a lactate of 20. Drug screen was negative. Alcohol levels were negative as well. Chest x-ray, bilateral patchy infiltrates seen there. Echo was hyperdynamic, EF greater than 55%, no wall motion abnormalities, and then no pericardial effusions. So, first question. Patient's height was 167 centimeters with an idle body weight of 58.7. We say, which tidal volume would we choose? All right. 350, that's correct. So the vent settings were set for 350, rate of 30, PEEP of 18, FiO2 of 100%. Plateau pressure at that point in time was 52. ABG showed a pH of now 6.9, PCO2 of 50, and a PO2 of 90. So she's heavily sedated, RAS -5. She's seen with the vent. P-to-F ratio was 90 at this point in time. We say, which intervention at this point would have showed to improve mortality? Neuromuscular blockers at this point in time. So she was started on cisatracurium. Vent now is at 320, rate of 35, PEEP of 18, FiO2 of 100%, and a plateau pressure of 33. Her gas came back at pH of 7, PCO2 of 34, PO2 of 93. So she continues to have saturation of 88%, P-to-F ratio is now 93, and a plateau pressure of 33. Which of the following options at this point has been shown to improve mortality as well? All right. There we go. So prone positioning is correct at this point as well. The patient was placed in prone position. Protocol 16 hours, prone 8 supine. pH is now 7.2, PCO2 of 30, and PO2 of 75. Plateau pressure is now 25. So for this point, no correct answer necessarily, but want to get an idea of what people would, what would be their next step at this point. So airway pressure, ECMO, current management, or pulmonary vasodilators. Still moving. All right. Looks like we settled out. So we continued management. She was prone for 48 hours and paralyzed as well. She was started on CRT. mechanics significantly improved, and she was discharged 21 days after her course in the ICU. All right.
Great case, great presentation. Good morning, everybody. I'm Alex Arroliga, and I'm going to review in a short period of time the use of neuromuscular blockers in ARDS and what is the evidence that support that. So I don't have any conflict of interest at all. This is the outline. What we're going to do is try to tell you how we have been using the neuromuscular blocking agent over the last 50 years that we have been using it, and tell you about the paper that has been mentioned earlier that improved the outcomes of these patients, specifically about mortality, and briefly talk about interesting information regarding the potential mechanism, how this group of medication are useful, or how do they work to improve the outcome. This group of pharmacological agent has been used for the last almost 70 years, and in 1975 was the first time when pancuronium was suggested to be used in a small cadre of patients with ARDS. We published a study in mid-2000 about the use of this agent in the alveoli study. And there was a significant percentage of subjects that were using this medication or were receiving this medication, around 30% in the low PEEP and 25% in the high PEEP. And subsequently, over the 28 days, first initial 28 days of observation, a good percentage of these patients were received the medication. It was not associated in this study with an increased mortality. In the more recent studies published in JAMA last a couple of years, it was mentioned that it was being used in 37% of the patient with severe ARDS, defined as a PF of less than 100, and the use decreased based on the severity of the condition, 18% in moderate and around 6% in those with mild ARDS. In general, was used in people who were sicker by different markers of severity, including not only the PF, but the evidence of organ involvement, and tend to be used in those subjects or in those people where there is a high mortality. Now, this is an interesting study published last year in the Annals of the ATS. And what you see in the horizontal axis is degree of severity of hypoxemia, and the vertical axis is percentage of patients who receive the treatment. And the dark blue is those patients who have refractory hypoxemia, defined as a PF of 60 or less. And if you see the dark blue in the middle is neuromuscular blocking agent, and it was used in around 2/3 of those patients who have severe refractory hypoxemia. On the other hand, in the far left, you have the patient who received corticosteroid, and the percentage of those patients was less than those receiving neuromuscular blocking agents. So in summary, it's being used rather frequently, and not a surprise, it's being used in those by whom the different markers suggest a higher degree of severity, organ dysfunction, or severe hypoxemia. In the 2010, in the New England Journal of Medicine, there was a study published from France based on an initial observation in 56 patients in which a neuromuscular blocking agent, in this case cisatracurium, was given for 48 hours, and it was associated with improved oxygenation and a lower mortality. It was associated as well with a reduction of the different markers of inflammation in those patients who received the medication. Then the study that was published in 2010 supposed to answer the following question. If a trial of short period of cisatracurium mesylate followed by an infusion, continuous infusion for 48 hours versus placebo, did that improve outcome? And the outcome was mortality. 20 ICUs, 360 patients, and those patients were receiving invasive mechanical ventilation, a PF of less than 50, tidal volume between 6 and 8 ml per kg, and bilateral infiltrates in a short period of time. So it was done early during their stay in the hospital. The use as is control, If the plateau was high, then it was allowed to be given cisatracurium, even if you were not in the study groups. The primary outcome was mortality at 90 days, and it was a study that was reasonably powered to detect a 15% reduction in mortality, assuming that the mortality at 90 days was 50%. 340 patients were included. It's an experiment. 25% of those screened, and it was done early, as I mentioned earlier, 16 hours from diagnosis, less than a day since being intubated. And this was the main outcome. The main outcome was that the patient received total volume of 6.5, PEEP of 9, relatively low, ICU mortality of 29 and 38%, which was not statistically significant, and the crude 90-day mortality was 31% versus 40%. And the P here is 0.08, but when you adjust it using Cox regression for PF ratio, SAPS 2, and plateau pressure, the mortality was lower. 0.68 HR was lower in those patients who received cisatracurium versus those who received placebo. Now, this mortality was significantly lower if you see the panel in the left side were patients with a PF less than 120, the one in the right side is PF above 120. The improvement in the mortality was observed in those patients that had a lower PF ratio. Now, without explanation is the fact that if you see the improvement in the mortality occur or start separating by day 8 or by day 10, when keep in mind that the medication was given only for 48 hours. So there was other improvement. Gas exchange was better in the study group. Ventilator-free days was better. Pneumothorax was lower. So the conclusion of the study was the administration of cisatracurium early in the course of severe ARDS was associated with improved outcome in those patients who were receiving a low total volume. Subsequent meta-analysis, I'm just showing you this one published in 2013, but there's another one published recently last year with the same studies basically show that the mortality improved at day 28, ICU, as well as 90 days mortality. The other piece of information supporting the use of neuromuscular blocking agent comes from this paper in 2014. This is a retrospective analysis of a big database. The database is called Perspective, and they included patients who received neuromuscular blocking agent for at least 1 day during the first couple of days. Primary outcome was in-hospital mortality, and they used a very sophisticated, beyond my understanding, of non-parsimonious logistic regression model to try to figure out the patient's propensity for the treatment. So 1,800 patients received neuromuscular blocking agent. They tend to be younger, male, sick, on pressor, and require other organ support. They were treated for 1.5 days, and the mortality was 31% in those treated patients versus 38% in the group of patients that did not receive the therapy. And this is the table. You see in the second row, you have mortality, 33% for the overall group, 31% for the treated patients, and 36% for the untreated, and that was statistically significant. Length of stay was a little bit shorter, and ICU length of stay, a ventilator-free day, was no difference between the two groups. A recent paper published in January of this year, using a similar methodology and a similar database, they try to answer the question, is this the neuromuscular blocking agent, or is this a specific agent such as cisatracurium? And they compare cis versus vecuronium in this sample of patients with ARDS, 1,900 in each group. And they found that those patients who received cisatracurium, they didn't have a lower mortality or hospital length of stay, but they had less ventilator-free days and less ICU days. So it didn't answer the question if it improved mortality and if it was related to a specific medication. Now, let me go to the final part of this very short talk. We talk about the possible mechanism, and there has been several mechanisms suggested. So they say that if you paralyze somebody, you will avoid the volute trauma, you will avoid the atelec trauma. And for some of you who are interested in the subject, the editorial by Dr. Slutsky to the 2010 paper in the New England Journal is an outstanding one. But there are other evidence coming up as well that will be interesting. In this slide, what I wanted to show you is in the bottom half. In the left side, you have animals who have severe lung injury and did not have spontaneous breathing because they were paralyzed. Compared with the panel in the right side, in the bottom right, those animals who had severe lung injury, but they did have spontaneous breathing. And if you see, even if we're not pathologists, the one in the right looks significantly worse in terms of the inflammatory process compared with the one in the left side. But the most interesting information, I think, is coming up from the anesthesiology literature. The receptor, the nicotine receptor for acetylcholine has pro-inflammatory property and promotes neutrophils activation, release inflammatory cytokines as well. So I'm going to show you a couple of results from a rat and mouse modeling of lung injury with the following hypothesis. Is neuromuscular blocking agent protective against ventilator-associated injury by their anti-inflammatory effects mediated by blocking activity of the receptors in the epithelial, endothelial, as well as in the leukocyte? So this is cytokines level, TNF in the upper panel, interleukin-6 and inflammatory cytokines in the lower panel, BLF, BAL in the left side, plasma in the right side. If you concentrate in A in the top corner on the left, the last two columns are animals who receive C-cetacurium as well as pancuronium. And you see that they produce less inflammatory cytokines, at least of TNF in the bronchoalveolar lavage, and in plasma significantly lower compared with those animals who were ventilated with asynchrony and with synchrony. The suggestion here is that it's more like a group effect and not only the C-cetacurium. And when they use stimulated CD14, the last two columns in the right as well are evidence that at different concentration, the medication decreased the productivity of inflammatory substances. So they concluded that this anti-inflammatory property is independent of the effects of synchrony, and they be mediated by the receptor expressed on epithelial, endothelial, and CD14. The last paper that I have is this one published this year in Critical Care. This is kind of a complex figure, but let me walk you through. What you have in the left is surfactant protein D. In the middle is von Willebrand factor. And in the C, in the right side, is interleukin-8. And what you have there in the middle is 0, so is the substance going up or down? And what we have is in the 4 groups, group with severe hypoxemia, PF less than 120 and low tidal volume. And and then you have PF 120 and high tidal volume, and so on and so forth. So 2 groups with a PF more than 120, and 2 groups, one with low tidal volume and high tidal volume. And this is data from the initial study of the ARDS net that were analyzed based on these inflammatory substances. And suffice to say that in those patients that were given neuromuscular blocking agent, the rate of decline between day 1 and day 3 of these inflammatory substances was attenuated or was reduced by the administration of the neuromuscular blocking agent, but it only worked in those patients that they have severe hypoxemia, PF less than 120, and they were receiving a low tidal volume. And this is extremely important because, as you know, in the many epidemiological studies, still 35, 40%, and in some cases up to 50%, people are not getting a low tidal volume. They think they are getting, but in actuality, they are not receiving the low tidal volume. So in conclusion, neuromuscular blocking agent improve oxygenation, reduce oxygen consumption, improve interaction. They may reduce volume and biotrauma, and they may have anti-inflammatory properties. However, there are still many questions. Is the survival benefit only in those with severe diseases? Separation and mortality appear late in the disease course. How do you explain that? There may have been that many of these studies have been under power, so we're eagerly waiting. I think they already finished enrollment in the ROSE study. It's going to be 1,400 patients, and it is estimated to be finished this year. I hope that we will have some new information by next year. Thank you very much for your attention.
All right. Thanks. I'm Bob Heise from University of Michigan, and I will tell you that the ROSE trial is through, and we will have more information. All right, so I get to talk to you about proning, which is great because you all voted for it, and that's good. And so we've got some more polling for that. I have no conflicts of interest. Here's a picture of Kathy Volleman. I'm going to move fast in deference to my colleagues. How many people use proning for severe ARDS? Okay, put your hands down. Now I'm going to turn my back. How many people say they use proning, but they don't really do it? Okay, put your hands down. All right, that's that. No, I'm done. I can sit down. That's my whole lecture. All right, so proning's a good idea. Can we all agree on that? You flip people and you redistribute lung volume. Isn't that wonderful? We've got a question for you. In severe ARDS, which treatment modality is, now it's a negative question, is not recommended by current guidelines? No tidal volume ventilation, prone positioning, higher PEEP, recruitment maneuvers, or high-frequency oscillatory ventilation. Advanced slide, advanced poll. We should have our poll. And that's correct. So you, in the Canadian trial, Oscillate had increased mortality. So that is the correct answer, which means to say, you betcha, the other things are recommended. And here are the guidelines that came out in the Blue Journal last year. And I've got a little box around proning, which in guidance parlance, a strong recommendation of at least moderate quality evidence is pretty good. And it's hard to get better than that. So as you see, the only other strong moderate on there are the negative for oscillation, but lung protective ventilation, which no one's going to argue about. Now, why is that? Of course, the ProSeva article. Here are the Kaplan-Meiers for that, big treatment effect. But, you know, everyone's been reading the tea leaves on ProSeva now for, my gosh, 5 years. One way to read the tea leaves is say, look at the treatment effect on a forest plot relative to famous critical care trials we all know and love. Here's ARMA down here. Does that work? Or there it is. So critical care trials are like making sausage. Tastes great, but you don't want to know what's inside, which is to say it's hard to do clinical trials. It's actually hard to get a positive clinical trial, and yet, lo and behold, there is ProSeva, way out there, big treatment effect. People would argue that they finally did it right. They finally used lung protective ventilation, they finally proned long enough, and indeed, in only sick patients, and when you look at meta-analyses that separate this out, really only moderately to severe patients appear to benefit, and you got to flip them over for at least 12 hours a day. So if you do it right, maybe, and with the proper patient population, then you may help the patient with actually a mortality benefit, right? That's what it's all about, mortality. Yet, prone ventilation is underutilized. This was from the LungSafe article. I could have just as easily shared with you the Canadian trial in the White Journal that Alex just shared with you. He didn't comment on proning, but trust me, in that bar graph for refractory hypoxemia out of the Love's protocol is proning being underutilized. So like I said, I turn my back. Yeah, we're all friends here. But proning is underutilized, and yet how much does it cost? Well, you could argue nursing hours. The one joke I usually make about my first slide is, what's wrong with this picture with Kathy Volleman proning someone with the prone positioner? It's only one nurse doing it. You could argue the man hours are not factored in, so it's not really free. Now, there was OPRANET, which came out this year in the intensive care medicine, which tried to analyze why this is not being done. Why are we falling short with something that's mostly free to do, which has a mortality benefit with proper patient selection? And to read the fine print here, and it's hard to see from the back, this is just cut and pasted right from the journal article. But basically, the patients say, you're not sick enough. But we already know from LungSafe, by the way, that ARDS is under-recognized, lung protective ventilation is underutilized. So to say that I'm not going to prone them because they're not sick enough yet might be a bit of a fallacy. You might be on the wrong track. And when you look at this slide as to the multivariate analysis, and it's a little bit tricky here because it's a double negative. Odds ratios less than 1 reduces the risk of not being prone. Can I see what I'm saying? So it's the things over 1 that bug you. But it is saying that, oh, gee, if your FI2 is more than 60, if your plateau is up, you're more likely to get prone. Or if you're on a lot of PEEP, you're more likely to get prone. Hold that thought. I'll return to that. And the people that don't seem to be getting prone are immunodeficiency patients. I don't know. I'm not. This is an interesting article because you kind of wonder why are we falling short? I'm not sure it's informative other than say the data repetitively show we're just not doing this enough. Now, Ivor Douglas, my friend from Denver, they prone. I rounded there one morning, and they prone. Okay, so it's on the front burner there. And I have to say, even my own institution, now that the oscillators in the dust in the closet rather collecting dust, I'll get someone on a high PEEP, and if that's not working, proning will be my go-to thing. And should I do that or should I not? I don't know, but I can tell you this. I'm also an ECMO center. And it's a little disturbing because this looked at papers that related to ECMO and ARDS to see what treatments they got. And really only about 31% received a trial of proning before ECMO. 69% did not. And this, I think, was Alan Walkey's work, this excellent work out of Boston, and I think the phrase was unproven and expensive before proven and cheap. Now, we can argue about Eolia, whatever, but the point of the matter is, don't you think you ought to flip people over before you cannulate them? I mean, I think you see a lot of heads nodding, and hopefully that's true. So just as a reminder that in the ProSeva article, they actually tried to make people better. They didn't know, Ivor, God bless them, I mean, they were flipping people prone and they hit in the ear. No, I'm just kidding, but early. But if you read the fine print, you were trying to actually make people better. So you were still having a PDEF less than 150 on at least 5 with lung protective ventilation. So you got a 12-hour rule here. And in fact, I'll show you some, if you want to show up to the ARDS update, there's about 24% of people with ARDS in day 1 that don't qualify in day 2. So in other words, maybe you shouldn't flip people over that are mild, that get better in a hurry. Okay. But this is relatively cheap. It is, you have to flip them for 16 hours. Yeah, you make it a little abrasion on the forehead, and the issue of VAP is, I think, in play here. And it does take a lot of people. But it's hard to beat an intervention. For all the things we do, nitric oxide, for example, which juices up your PO2, but no mortality benefit. It's certainly easier than proning, but it's expensive. So question 2 then is, 60-year-old ARDS who's on lung protective ventilation, PPLAT's 13, PEEP at 12, but PO2 still iffy. So we're not quite there yet, but in terms of still being hypoxemic because the patient's on a pretty high FiO2. Now what do you want to do next? Increase the PEEP to 15, put them prone, start NMB, refer for ECMO. And you get to, this is a trick question because there isn't a right answer. This is an opinion piece. So you get to have an opinion. And well, kind of even, well, so no one's going to ECMO because they showed you not to, right? That's good. So at least, so you're listening, which I guess makes my day. But we have almost an even split on the other 3, don't we? And so one of the issues I wanted to bring out to you is that if you, and so I would argue the next 2, because G's, it is patient not on a whole lot of PEEP. Now, one of the fallacies here is I defy you, although the true believers will tell you, you don't have to paralyze people to prone them. I don't know where, again, I've met at Denver General folks. I think you kind of have to. In ProSeva, they were. So again, it's a real trick question. But the point I really want to make for you, and it's my last point, is that actually proning trials are low PEEP trials. In other words, you got your ARMA, low PEEP titration protocol, if you're familiar with that, and you've got your alveoli or LOVES, high PEEP, the kind of separation, usually 40 is the cut point, 40% FiO2, 18 to 10 centimeters water PEEP. That's a high PEEP protocol. We're now calling that high PEEP in the wake of our trial results. And in fact, most of these proning opens the lung, right? I showed you flip the burger and you back of the lung, way to the heart. Good, perfect. But these are low PEEP trials. And so it's interesting because I'm actually not flipping people at 5 a PEEP or even 8, right? I'm cranking up the PEEP. And I'm getting to 18 to 20 instead of, like I said, my oscillators collecting dust. But I'm not sure actually I'm using proning I'm not using it as it was in ProSeva. It wasn't a high PEEP protocol first, then flip them. It was, okay, you gave them 12 hours, things aren't working out. But it was not a high PEEP titration. So it's interesting in this review to demonstrate that actually we're not necessarily sure that high people's proning is any incrementally better than high PEEP alone. That study's never been done. These studies tend to be low PEEP protocols. And that's something I've always been aware of. I'm glad to see this in print. All right, so I've had 10 minutes with you, and so I'm going to wrap up, so in deference to other speakers. So should we routinely prone patients with severe ARDS? So the operative words here are routine and severe, right? Okay, so severe. We're not talking about that guy getting better in 12 to 24 hours. But we're talking about persistent severe disease, which has a higher mortality, I assure you. And I would say yes, and I'd say flip them. and or high PEEP. And I don't know, and I wish I could tell you, but that the combo of the two is the right thing, but I do it. So we don't really know how to position proning. Should you do it before you get to a high PEEP algorithm or after? Is it incrementally better? Certainly in PROSEVA, some people were on high PEEP, but they didn't have to be on high PEEP. So we don't know the answer to that. The role of using both concomitantly is unknown. So that's what I have for you, and so I'm glad you all agree with me, and hopefully after listening to me, we'll all use proning more. Thank you.
Hi, Dan Ouellette again. I'm going to talk with you a little bit about recruitment maneuvers today. One of the things that I would like to put a plug in for is a session tomorrow afternoon where Bob and I are going to talk about, we're going to debate recruitment maneuvers, and there also, as part of that session, will be a pro-con session on ECMO. So come tomorrow if you want to hear about that, and I think it'll be fun and exciting. As I said, I'm from Henry Ford Hospital. These are my disclosures. There are none that affect our talk today. And what we're going to do today is to try to understand the types of recruitment maneuvers that one can employ in patients with ARDS, to learn about advantages and disadvantages of using recruitment maneuvers, and to study the available evidence. So I think that this is a slide from Grasso's article in 2009, and I like it a lot because it was an animal model where they used CT scans, and they used a couple of different methods for creating ARDS in the animal models, and then they looked at open lung and closed lung strategies and looked at the distribution of ventilation. And the reason to put this slide up, I thought that the pictures were really nice in a way in that they demonstrate that ARDS is a heterogeneous lung disease. And so we are all challenged in our patients by wanting to recruit areas of lung that have not been recruited, but we're concerned at the same time about causing overdistension. And when you see pictures like this, you realize you may actually be doing both by using some of the measures that we employ. And so using them judiciously is important. Measures that we know improve ARDS outcome include low tidal volume ventilation, aggressive volume management of our ARDS patients, optimal high levels of PEEP, and we're talking about paralysis and prone ventilation today, and I'm on board with those things as well. But with recruitment maneuvers, I think we have a balance that we're trying to strike. Are we causing alveolar recruitment and therefore improving outcomes, or are we increasing alveolar distension and causing adverse effects? And are there other adverse effects from using recruitment maneuvers, including effects on hemodynamics? When we look at doing recruitment maneuvers and we strive to re-aerate non-inflated lung, there are a couple of parameters that are important. We have to think about the magnitude of the inflating pressure with our recruitment maneuver, the duration of the sustained pressure, the inflation time product, and we have to think about frequency of our recruitment maneuvers as well. The problem is that I struggle to know how to do them exactly because every time I look at a different article, they're done slightly differently. And so do you use CPAP at 40 for 40 seconds? Do you use PEEP at a certain level? Do you use incremental PEEP? I don't know. And the problem isn't only that I don't know or that you don't know. The problem is when we look at the literature on this topic, everyone's doing it differently. And so there's a heterogeneity in the literature that's hard to get around. So in terms of CPAP as a recruitment maneuver, they used, in this study in 2017, pressure-targeted assist control with a driving pressure of 15, PEEP of 25 for 1 minute, PEEP of 35 for 1 minute, PEEP of 45 for 2 minutes, and then decremental PEEP to try to find the optimal PEEP. And then halfway through this study, they altered the protocol. This is another study from 2008 where they used something called an ESI, and the graphics of this mode of ventilation are depicted for you. And this is another way of doing recruitment maneuvers. So they're done differently in different studies and in different circumstances. I have a question for you. I forgot to tell you guys how to use the app to answer the questions, but I was watching you and you already know. So one of these is correct. In a recently performed systematic review, Which of the following outcomes was significantly different between patients treated with recruitment maneuvers compared to those not treated? In-hospital mortality, 28-day mortality was improved, ICU mortality was improved, barotrauma was more common, and I think we can look. And you guys must have read the systematic review because you're right. Or wrong, actually. ICU, in a recent systematic review, ICU mortality was improved. I'm going to show you that. This is from a systematic review that was done by Hodgins in 2016. And unlike what you might think about the barotrauma, actually what they found was that ICU mortality was improved. And there are 5 studies collected at the top and 2 studies at the bottom. The reason for that is the 5 studies at the top included recruitment maneuver in a group of other interventions that they performed. And so that's one of the problems with this systematic review. The other problem is that there's a heavy weight given to one study because of the N in that study, and that's represented in the blue box. But the overall effect was that in this systematic review in 2016, mortality was actually improved. When you look at the recruitment maneuver only group, that wasn't quite true, but the overall effect was good. So the problems in this Cochrane analysis, this systematic review was in the Cochrane database, is that there was a lot of heterogeneity between the trials in terms of how the recruitment maneuvers were done, and also in the fact that the recruitment maneuver was one of many interventions in several of the studies. There was some of the studies, because of the weight of the effect they had on analysis, were weighted more heavily. And the degree of the confidence in these findings were low. A lot of us has looked at this study where there was a recruitment maneuver and titrated PEEP versus low PEEP in ARDS. And in this study of over 1,000 patients, large multi-center study, these patients had moderate to severe ARDS. And in the experimental group, they had a recruitment maneuver that was done by incremental PEEP. This is a study where they changed the fashion of doing the recruitment maneuver partway through the trial, and then they sought to find optimal PEEP by a decremental strategy. The control group used a low PEEP strategy. And the primary outcome they studied in this effect was 28-day mortality. The secondary outcomes that they studied were length of ICU stay, length of hospital stay, ventilator-free days, pneumothorax or barotrauma, and mortality. And in this study, they found that the difference in mortality was not significantly different. They did find, however, that the group that had the recruitment maneuvers suffered more barotrauma. So this finding in this recent study is different from the Cochrane analysis, and it's probably the one you guys were remembering when you first answered it. The Cochrane analysis actually shows a slight benefit for mortality. This study didn't reproduce that well, at least in terms of ICU mortality, but did show that barotrauma was increased. There are signals for improvement in ventilator-free days and 28-day mortality, however. So recruitment maneuvers in ARDS. I don't think that we've demonstrated that consistently that clinical outcomes are improved by using them. They may lead to an increased rate of complications, such as barotrauma. I think that we need to look for standardization of performing recruitment maneuvers, and I think we need more research in this area, but I'm not sure that we're ready to have recruitment maneuvers part of everyday practice, because I'm not sure that we've demonstrated that the balance of effect versus adverse consequences has been clearly demonstrated, and the data is filled with a lot of heterogeneity. Thank you.
Good morning. I'm Jorge Velasco. I'm the medical director of the ECMO program for Baylor Scott & White in Temple, Texas. Temple is about 2.5 hours from here, So you know you are in Texas because the distances are measured by the hours of driving. It's not 60 miles, no, it's 60 minutes, 1 hour, 2 hours. So we're far, but not that far. So I will say thank you to all of you for coming to Texas. So I don't have anything to disclose related to this topic, but I will say that the FDA is considered off-label usage of ECMO for some of the conditions that we're going to talk about. So what I'll try to do is just try to explain the role, the indications, and the potential complications of the use of ECMO for patients that have severe ARDS. Why is this important? Because the patients that are extremely ill with ARDS, the ones that have a PF ratio of less than 100, the mortality has been shown to be extremely high. On all these 3 series, you can see the mortality being between 70, 60, 70%. So it's a high mortality condition for these patients. It's not a common condition to have severe ARDS, but whenever it does happen, you're going to die from it. This table was taken from the New England Journal of Medicine, published in 2000, and it's basically the landmark study that will tell us that it's a great idea to put the patients on low tidal volume ventilation. So the patients that were ventilated with 60 Cs per kg or predicted body weight, they will have a statistically significant lower mortality. That lower mortality will be about 11%. So I want you to keep in mind that number and say there is a difference in mortality of 11% with this therapy. And this is what is now standard of care. So how about ECMO in ARDS? That's been studied for a while. It's nothing new. So ECMO can do a lot of things for you. And one of the things that it does, it saves patients' lives. So when you get all this stuff about all the randomized controlled trials and all these things, sometimes the patients don't read the papers and they're going to die on you. So you have to have something available for you to be used. So ECMO can do a lot of things for you. The patients on ECMO will not die of oxygenation failure. The majority of them will die from multi-organ system failure. And some of these patients also will have a lot of complications related to this therapy. But now when you question this therapy and you say, ECMO has been available for the management of respiratory failure for the last 50 years. So we're talking about a therapy that is being available for 50 years and has not made it to the mainstream, has not made it as standard of care. So you think about it and you say, there's something wrong with this thing. Why is not adopted? But you see the things have changed. So this is a picture of a case report from the New England Journal of Medicine. This individual had a transection of the aorta. He was given a lot of fluid. He went in ARDS. And then he was placed on VA ECMO. So that is VA ECMO in 1972. So you can see the pump by itself being so big, all the tubing, all the blood outside. The patient was on ECMO for about 17 hours and was able to survive and be discharged home. So this is a therapy that cannot be sustained. But if you talk about now, when you have the oxygenators that are this big, the cannulas, some of the cannulas may be as small as just a little bigger than a dialysis catheter. Okay? So what you're going to do is you're going to place a cannula in the femoral or the vein or the neck. You're going to retrieve the blood, pass through a pump, go through the oxygenator, and then return oxygenated blood to the patient. And the pumps work really simply. If you see the oxygenator on the right-hand side, you're going to have the venous blood coming in. You have all these fibers that will have a gas content. And as you can see, the venous blood is rich in CO2 and poor in O2. As the gas goes by, there is a diffusion, so you're going to get the oxygen out and you're going to get the CO2 into the fibers. And now, just going from one side of the oxygenator to the other one, you are arterializing the blood. You're making it from venous to arterial, and then you return it back to the patient. And now it's possible because the fibers are so efficient, the pumps are so small, and the oxygenators as well. So, but we should never lose perspective and think about the therapy for ARDS. If you see in this table, you're going to see different degrees of severity. You see the patients, by definition, is now adopted by everybody. We have mild, severe, mild, moderate, and severe. So the patients should only be treated with the standard of care. And those are, I tried to mention there, 3 things: prone positioning, high PEEP strategy, and lung protective ventilation. The rest of it is not proven. That's why it doesn't have a role as the standard of care. So if you see on the far right where the patients are the sickest with PF ratios in between 80 and 60 and 50, all these things are called rescue therapy. And that is where you find ECMO. You don't find ECMO as a lung protective ventilation. You don't find it for patients with mild ARDS or for moderate ARDS. It has a role, but we'll see if we can delineate that clearly. Once you face these patients, it's extremely important to selection a good population because you want to give this therapy to the patients that really need it. You don't want to give it to patients that don't need it, or you don't want to use an expensive proposition for patients that are going to die anyway. So this is a scoring system that we use, and it's being validated in the literature in ECMO. It's called the RESP score. It will give us an idea of how old the patient is, how long the patient's been on mechanical ventilation, has the patient had a cardiac arrest before going on ECMO, has the patient been on nitric, and all these things. So once we use this tool, we will be able to select the patients and say, these patients are in a risk class. So the chances of dying if you are in class 1 will be about 8%. So as I said, this therapy will be for the severe ARDS, the ones that are gonna die 60 to 70% of the time. So then our population will be the groups 3 or 4. We're not gonna give it to patients in the group of 5 because their mortality will be about 92% and we probably won't save those. We do use additional scoring systems because those will help us to use this therapy properly. So the SOFA score is very useful. It doesn't have a great area under the curve correlation. The Apache 4 has a better correlation. But we do use the SOFA score because now the SOFA score is widely available. It's part of the sepsis initiatives. So if we get a call from another hospital, it's very easy for us to just ask, what is the SOFA score on your patient? So if your SOFA score is higher than 40, so your mortality is gonna be probably 70 or so, 70%. So we probably will not place those patients with severe ARDS with a high SOFA score on ECMO. And the same applies to the Apache score, the Apache 4. If you see, they have a predicted mortality of 49%, so those patients basically will die close to 100%. So when we use this screening tools and all that, so we can say, okay, this is a proper patient that may be screened for this therapy. But anything we do in medicine should be based on evidence because that's what is the right thing to do for the patients, for the system, and all that. If you can see here in this table, we have minimal research on ECMO. If you see here, VA ECMO, the literature is filled with cohort studies, case reports, no randomized controlled trials. For respiratory ECMO, for VV ECMO, for ARDS, we have basically 4 randomized controlled trials. So, and 2 of those were old. One of them was comparing ECMO with inverse ratio ventilation, so that's out of the picture. The other one was VA ECMO, and the patients were just stopped at the end of the allotted time. So those are not good trials. So basically, we have only 2 trials to choose from to decide if this is a good therapy or not. The landmark study is called the CESAR trial. So this was a multicentric trial that was published in Lancet in 2009. If you see here, it took about 5 years to be produced. It included 103 hospitals, and the idea was to randomize the patients and say, we're gonna have, in this case for this study, to prove, to have power, to have 180 patients, and we're gonna randomize them to cannulation and ECMO therapy or to conventional therapy. All the patients that were supposed to be cannulated and put on ECMO were transferred to the center in Leches there. So that means like every single patient that was gonna be on ECMO was gonna be referred to this center. And the primary outcome was death and severe disability at 6 months. So the problem that we have with the trial is that you selected those 180 patients, but 90 of the patients that were supposed to be going on VV ECMO, 16 of those patients did not make it in that group. Why? Because as soon as the patients got to the referring center, they were able to provide a standard of care medical therapy for ARDS. That means they dropped the tidal volumes to 60 Cs per kg. With just that intervention, they were able to prevent a chunk of population of this group to go on ECMO. So that it's making the study flawed. So, but that's the first one we have. And whenever they did the analysis at the end, it proved that it was a positive study. But with that flaw, it's difficult to make a name for that therapy. But what happened later is we have all these influenza epidemics and all that. This was a relatively positive study, so ECMO therapy was adopted so aggressively in the world. So what about now? So this is a study that just being published this year in the New England Journal of Medicine. It's called the EOLIA trial. And this trial is kind of a replication of the CSAR trial. It has the same heavy exclusion criteria, inclusion criteria. It is a very well-written paper. So what we have is a multicentric international study. It was randomized controlled trial based on the severity scoring that is being adopted in the Berlin definition. We have the patients that should be on mechanical ventilation for less than 7 days, and they will initially, to have the power to have a good study, they were supposed to recruit 331 patients. But if you can see in the paper, they were only able to recruit about 249. If you read the documents and all the editorials afterwards, you see that the rate of recruitment for these patients in the ICUs was minimal, maybe 1 or 2 patients a year per center. And if you can see, there were 64 ICUs. The immense majority of those ICUs were in France because the study was supported by the French government and the company. There was the Alfred study in Australia, that is an excellent ECMO center. We have Columbia Presbyterian in the US and Toronto University. So as you can see, the study was planned to last 4 years, but it took them 6 years, and they didn't even achieve the final number of recruitment. And then at the end, when they did the 4 sequential interim analysis, they found that the study was flawed, and they have to stop for futility. So, but I want to get your attention to this chart. Look at the patients, how extremely ill they needed to be recruited and placed on ECMO as therapy. They should have a PF ratio of less than 50 for 3 hours on maximal therapy, a PF ratio less than 80 for more than 6 hours on maximal therapy, or have significant respiratory acidosis for more than 6 hours, with tidal volumes all the way down to 4 cc's per kg, with a plateau pressure less than 32. So they were extremely selective in the patients they put on this treatment. But whenever we analyzed the data, we found that it happened exactly the opposite to the CSAR trial. So now you have all these 249 patients, you have 124 that were randomized to get the ECMO therapy, and you had 125 that were randomized to get the conventional treatment. However, the study had in their protocol that there was a possibility of crossover to ECMO as rescue. So the patients that were dying on the conventional group were able to go and be treated with ECMO therapy. And now it happened, as I said, the opposite of the CSAR trial. Now you can see that 35 patients out of 125, 28% of the patients that were supposed to just get conventional treatment went and received ECMO anyway, okay? So that also puts a black eye on this study because you didn't recruit enough patients, you don't have the power to show your outcomes, and a lot of the population is jumping into the treatment group, okay? If you go in detail on the chart, you will see that this population was extremely sick and well-selected. The PF ratio was in the 70s, the PEEP was about 12, tidal volume for both populations was 6, plateau pressures less than 30, but what it calls my attention also is they didn't use that much pronin. If you see here, my computer is really blurry, but you see on the ECMO and the control group, the numbers for pronin were really low, okay? Neuromuscular blocking agents were given in a majority of the cases. So these 2 tables are basically the meat of the study. The one on the right is the Kaplan-Meier curve that is published in the paper, and on the left, and the one on the right is in the supplement. If you were to see the first one, there is no statistical significance in the difference between the mortality at 60 days for these 2 populations. So the patients were dying 46% in the control group and 35% on the ECMO group. If you're a simple-minded guy like I am, you will say, well, there is an 11% difference. I saw that one in the paper in the New England Journal of Medicine in 2000. Maybe ECMO is great. I do believe ECMO is great, so that's why I'm here, I guess. So, but if you were to see the other table, what they did is they said, in the control group, we're going to consider those patients that were placed on ECMO, we're going to consider them failure or death, okay? In that case, the separation is wider. Now you have a difference in mortality between 57% on the control group to 35%, 22% difference in mortality with a statistically significant p-value now, okay? As you know, statistics is kind of an art and also a science, so you can change them as you want to prove a point. But at the end, when you write the papers and they're going to be published in the New England Journal of Medicine, you have to prove your points, and this study is a negative study, okay? This is a negative study for the use of VV ECMO for severe ARDS in a very selective population. There are other things that came out of the study as well that are kind of self-explanatory. Patients stay longer in the ICU whenever they were placed on ECMO. I'm going to call the attention again to proning. The patients on ECMO, 66% of them were prone, 90% in the control group. Why not 100% on the control group? Okay? And then, let's see what I have next. Well, I think I'm going to just close there. What I will say is that severe ARDS with a PF ratio less than 100 should be treated with proven evidence-based therapies like low tidal volume, less than 60 cc per kg of ideal body weight or predicted body weight, a higher PIP strategy, and prone ventilation. So the role of ECMO then should be used only as an unproven rescue therapy for patients that otherwise will die, after a multidisciplinary approach applying validated prediction tools. Okay, and with that, I'm going to close, and thank you.
We have 7 minutes left in the session, and the panel is open for questions. If you have a question, please come to the microphone. Sir.
Thank you for the talk. The never-ending issue about the steroids and ARDS. The SCCM actually in 2017 had a conditional recommendation for the use of steroids. The European Society of Intensive Care Medicine did the same thing. We're going to hear tomorrow from Dr. Maduri about the steroids and ARDS. What do you think about the steroids and ARDS?
You know, we had a session on Wednesday morning, cardiac eruptions session, that Steve Hollenberg asked me to participate in. That would be a lot of fun to have that there. This is the proverbial third rail of critical care medicine, and this is literature that I know and enjoy. I would say you are free to use them. I would argue, and I think the information is becoming compelling, that if you have influenza, I would shy off, particularly early on. But it is still an open question. With all due respect, Umberto, you know, the data is a gamish, and but in fairness to him, and he thinks I was actually strikingly fair one time, the notion of 14 days as a hard stop based on Lazarus, I think have very wide confidence intervals. So what I would say to you is that he would argue immediately, and I know that the Gilanan would argue even in influenza, but I would say if you have a flu, influenza that cause respiratory failure with ARDS, which we do get a lot of and we're about to get more of, I would caution you against that based on current literature. But I am not against them. I was part of the writing committee for Lazarus in 2006, which was a negative trial, as you know, and the Rorschach test of that was 20 versus 6 return to the event. An early mortality benefit for steroids appeared to be lost when 20 people had in the steroid group had to return to assisted breathing versus 6 in the control group. And the question there was why. And in Lazarus, we tapered steroids within 48 hours of coming off assisted breathing, as Roberto has said, which he argues by analogy. You know, if you have a patient with asthma, you get them off a ventilator, you don't stop their steroids. He said, well, that's a good point. So you are welcome to use them. Definitive study is lacking. In fact, Lazarus was supposed to be a 400-patient trial, got repowered to 180 because recruitment was slow. So I'm not against them, and I'm sort of for them, but I think I'm pretty much against them, especially early on, because I think that would be wrong.
All right, thank you.
Another question? Sir.
And maybe this is for the whole committee. There is a striking difference in the Kaplan-Meier curves between Eolia and Prosiva and accuracy. And I'm where in accuracy, the mortality really doesn't start to separate out to about day 10 for an intervention that took 48 hours. That's sort of unusual in critical care trials. And I'm wondering if anybody in the committee would care to opine why the Rose trial was stopped without a press release.
I'm a federal investigator, and I will tell you that in the scientific world, you want to have a high visibility publication for your results. And the editors of the high visibility journals require you to censor the results pending the ability to submit and revise and review and accept the manuscript. And
That's true, Bob, if people aren't dying with or without the therapy.
well, I understand that, and there have been in the past times at which, for example, ARMA, as you know, was a press release. I would say that times have changed, but I think your point's well taken, but that's just the way it works now. In my opinion, that's just, I mean, I'm not on the writing committee, Rose. You want Mark Moss is here, you go hang him, but, you know, Derek, I don't think is, but that's, I think basically, people want to get the word out, and we in the network want to get the word out. That takes a little bit of time.
Sir?
Can I go back and make a comment? I mean, I think it is extremely important to talk about medications, but I think the most striking question that we should pose to ourselves is why we, people here, and outside of this group in our community are still not using a low tidal volume mechanical ventilation in this space. And I think that's the key important question, is a 10% absolute reduction in mortality.
Because it doesn't work in everybody.
Well, that may be an opinion of which I respect.
That data was forced upon the critical care population by a small group of people based on ICU populations that were not studied in the trauma, complicated surgical population, or burn population.
I guess I have my answer. There's some opinion based on
There's
information.
a lot of controversy globally about low tidal volume strategy. Remember, it was only compared to 6 and 12.
Right.
What about the in between?
So you want a 10 and 8?
Who knows? It's individually dependent.
Yeah, this is a debate that goes back to
Exactly.
I
the
give your
year
dates
2000.
in OHRP circa 2005. And then when you do a protocol, you have to make choices how to do a study. I mean, that's just based upon one. But I will tell you, look at table 1. In ARMA, though, there was more broad representation of the population. What concerns me now, and I'll speak to this the next day, that right now, about 65% of patients enrolled in ARDS trials are CAP patients.
That's right.
And so we're really starting to skew things now, and that's a concern I have.
Sir?
I want to find out, like, what is the panel's thoughts of use of APRV as rescue therapy in refractory hypoxemia and ARDS?
Anybody want to
So I'll
venture?
talk about that and update mechanization. I'd be happy to give you that as foreshadowing tomorrow. I've been among the believers recently, and so I am certainly open-minded, but I'd be happy to discuss that at greater length tomorrow.
I have an opinion based on evidence as well. You know, we published a paper in intensive care medicine a few years ago. It's a retrospective analysis of a bigger database, and in that paper, we suggested it didn't work.
Okay, thank you.
Colin Grissom just had an EPUB in critical care medicine this past week, where they tried in APRV. They're getting tidal volumes often in excess of 12 per kilo. Now you can argue that given the releases, the true believers would argue you got to do it right. You have to individualize. You didn't do it right. Another thing you could argue is that lung stress and strain would not be necessarily as great when you're only releasing, a couple of times a minute versus a ventilator that's going in 35 times a minute. So, but that was what that article showed as well, and that just found that process at EPO.
Thank you very much for attending our session.
You're doing good, huh? You know, yeah, good. Excellent. That's good.
I'm doing, yes, I'm now the chief medical officer.
Oh, you are? All right, man. I'll get a pay raise for that. That sounds like a headache.
Thank you. That was good. That was better than I would have expected because at the time.
Yeah, that's a great question. Right. Well, I'll tell you what I do. I stick in a balloon and I give them high heat. You know, I think, anti-temporal, I've been 2 crowds, and those are also too. And I think the case is improvement extubating them, and real hacking and real literature on that. That's pretty scary stuff. Getting an airway closure or whatever. But I think it's a hard population, so I